Good afternoon. We have with us Dr. Bodhisattva Chaudhary, a critical care in charge at Parkview Hospital, Kolkata. We welcome you, Dr. Chaudhary, to the Natco Pharma Specialty Cricon studio. And what we look forward is your advice to the younger generation in the space of critical care associated with bacterial resistance. What we would like to know from you is how do you foresee the changes in the critical care management?
See, the most important thing we need to understand regarding the bacterial resistance that it is going to increase day by day. It's not something that's going to stop. We are already getting bacteria which is extended drug resistance. We are sensitive maybe only to colistin or fosfomycin, and now we are even getting strains which are resistant to all drugs. NDM, the various strains of Klebsiella pneumoniae, especially NDMs, Acinetobacters, it has become a menace in our ICUs. So the most important thing is antibiotic stewardship. We need to use our antibiotic very judiciously. We need to use the advances of modern therapies as and when possible. We use modalities like biofire or PCR testing in the early stage, and then whenever you get an antibiotic which is sensitive to other drugs, you de-escalate as fast as possible. Early de-escalation and using an official hospital infection control policy. This is very important. Every hospital must have an infection control policy. Talk to your microbiologist, talk to your lab in charges, take a data of last 6 months, see what kind of bacteria you're getting, what is the resistance pattern in your hospital, and make your decision based on that. That will be the most important thing I can say to our colleagues.
I like your term of stewardship, antibiotic stewardship. I think that's very nicely spoken there. What is your advice to the young ICU doctors for them to enhance patient care?
See, enhancing patient care in ICUs, in ICU, the patient care is always 24/7, but it's not possible for us to stay there 24/7. So, need to have a team. You discuss the things with your team. How do you want to approach the patient? Proper timely handovers, and handovers includes patient details and also the patient plan. Uh, the senior in charge who comes to round every day, he will see the patients maybe 2 or 3 times a day. He won't stay with the patient throughout the day. The younger doctors who stays with the patient throughout the day has much more responsibility towards the patient. Hand hygiene. This is something that I want to stress upon our junior doctors. We doctors are the biggest culprit on hand hygiene. Nurses do it better than us. We don't follow hand hygiene protocol all the time, but that must be done throughout the day in ICU for every patient, not just the septic patient, not just the patient who are immunocompromised, for all patients. Once we make it a habit, the chances of antibiotic contamination from one patient to one another will definitely come down. So this is the most important part I want to stress about. And whenever you do any procedure, where all the follow all the safety protocols, wear gown, wear cap, mask, sterile gloves, use them judiciously. If you are using the ultrasound probe, make it sterile under sterile cover so that you don't contaminate the area, you don't contaminate your procedure. Your procedure you are doing to save your patient's life should not be the reason the patient ultimately die of sepsis.
Thank you so much for being critical on the hand hygiene part, and I think that's very important. What is the prevalence of carbapenems producing bacteria in your practice, and what is the best treatment options?
So in our hospital, we do get a lot. And we deal with lot of immunosuppressed patient. We get a lot of cancer patient who have been on multiple hospitals and multiple with a long history of hospitalization. So when they come to our ICU with bad sepsis, we'll get multi-drug resistant bacteria all the time. Most common being Klebsiella, followed by E. coli. We also get few Acinetobacter and Pseudomonas. These four are the most notorious combination we get in our hospital. Because we do get a lot of cancer patients with a lot of immunosuppression. In these patients, it becomes very difficult to treat these patients because the bacteria is already multi-drug resistant. So in lot of patients, we can't use carbapenems. Carbapenem resistant strains are very common. If we do the antibiogram that we resistant genes we see, most common we get are CTX and NDM. This is the most common we get. We also get some OXA48. So these are the mostly combination we see. So based on that, sometimes we use, if the lung is the issue, we use polymyxin. If the urine is the issue, we use colistin. But even colistin using is difficult because using meropenem is not an option because already carbapenems are resistant. So for lungs, we use polymyxin V. For urinary infection, we use mostly colistin. Sometimes colistin cannot be used, or colistin can be used very low dosage because of the renal failures. So we had to use other drugs like tigecycline. For lungs, minocycline is a good option. If it is not an MDM, ceftriaxone avibactam is a good option. But all these drugs we have to use very judiciously. And whenever you get, we do send biofats a lot to understand what kind of bacteria we are dealing with, and depending on what kind of genes we are dealing with, and depending on that, we titrate our bacterial antibiotics. And whenever we get the culture report, we try to de-escalate as early as possible.
You just heard Dr. Bodhivasta Chowdhury, and we thank you so much for your time, Doctor, here at the studio. We wish you all the best in your practice. Thank you so much.